Welcome everyone to our webinar from WCLC23 to You, presented by Lung Cancer Research Advocates. We're thrilled to have you join us today for an exciting session. The IASLC STARS program is a global program with a global audience, and we're pleased to offer live interpretation in 6 languages: Chinese, French, German, Greek, Japanese, and Spanish. To enable the interpretation feature on Zoom, please follow the instructions shown on the slide. Select the interpretation globe button, select your language, and note that off will keep the webinar in English. Then select mute original audio so you are only hearing the webinar in your language. And our user guides in the offered languages are accessible through the link in the chat in Dropbox. We would like to thank our sponsors and our partners for their support of the IASLC STARS program this year. The goal of the IASLC STARS program is to help active lung cancer patient advocates evolve into patient research advocates. And the objectives of the program include to build a supportive network of lung cancer PRAs, to educate about lung cancer science and research, model effective ways to communicate science and research, and to identify research advocacy opportunities. We have a few housekeeping notes for today's webinar. Questions will be addressed by the panelists during the live Q&A at the end of the session. To submit questions, please utilize the Q&A window. And as mentioned, the language interpretation user guides are posted in the chat. Please note that the chat feature is not enabled for attendees, but please do send a message in the Q&A window if you experience any tech issues. And this webinar is being recorded and will be made available at a later date for viewing in all languages offered. We have 4 presenters and a moderator who will be sharing their insights and expertise with us. And this is a rare occasion as our presenters serve as mentors for the STARS program, and our moderator is a co-founder who helped develop the program. Our STARS mentors are the cornerstones of the STARS program, and their dedication, knowledge, and support have a profound impact on the growth and development of patient research advocates. I'd like to take a few minutes to briefly introduce each presenter. Dr. Upal Basu Roy is Executive Director of Research at Longevity Foundation, the preeminent lung cancer patient advocacy group in the U.S. He's trained as a cancer biologist and a public health researcher and has been a patient advocate for more than a decade. Upal is a champion of the power of communities. Andrew Kupek is Associate Director of Clinical Research at GoTo for Lung Cancer. Originally a lab-based cancer researcher, he earned his PhD from Baylor College of Medicine in Houston, Texas, and did research at several other institutions focused on understanding the biology behind resistance to various cancer therapies and discovering new therapeutic targets in cancer cells. Through his experiences, he became interested in how to achieve better patient-centric clinical research and care and deal with issues of cancer disparities and health inequities, leading him to a career transition to patient advocacy. Jill Feldman got involved in lung cancer advocacy in 2001 after losing her mom, dad, aunt, and 2 grandparents to lung cancer, and shortly after Longevity Foundation got off the ground. In 2009, at age 39 with 4 small children, Jill was diagnosed with EGFR-positive lung cancer herself. She's been a research advocate for 13 years. She's committed to understanding and promoting patient-centered research and sits on several notable committees and panels. In 2017, Jill co-founded the EGFR Resistors, and she is one of the original mentors for the IASLC STARS program. Dr. Anne-Marie Baird is an experienced cancer molecular biologist with research interest in inflammation and immune mediators, metastatic cascade, drug resistance, and disease biomarkers. She is currently a senior research fellow in Trinity College, Dublin, Ireland. Anne-Marie became involved in lung cancer patient advocacy in 2012, starting with her participation in the lung cancer social media community on Twitter. She is one of the founding members of the Irish lung cancer community, and she's president of Lung Cancer Europe. And Janet Freeman Daly will be moderating the Q&A today. Janet is a retired aerospace systems engineer, freelance writer, and metastatic lung cancer patient activist. Diagnosed in 2011, her focus is on translating the experience and science of lung cancer for others. She serves as a research advocate for thoracic oncology research programs at 2 NCCN facilities, various government agencies, and clinical trials. She has collaborated on research and education projects with lung cancer nonprofits, published research papers and science articles, and co-founded Lung Cancer Social Media Chat on Twitter, the Ross Wonders Patient Group, LCFA's Hope with Answers, and ISLC Stars. These experts bring a diverse range of perspectives to our discussion today, so let's dive right in and hear from our panel of experts and the STARS mentors. And with that, Dr. Upal Basu Roy will present first.
Thanks so much, Sarah, Janet, and the ISLC for giving me the opportunity to talk a little bit about the research that we presented at this year's World Conference on Lung Cancer. And the title of my talk is Exploration of Side Effects in Patient-Reported Outcomes in First-Line Compared to Late-Line Chemotherapy and Targeted Therapies. If we can go to the next slide. So I think a lot of you have seen this slide, and this slide comes from my dear friend, Jill Feldman, who's also on this call and who's a STARS mentor, and she's been an incredible mentor to me. And this is a very clear depiction of how the patient journey is incredibly complex. And we as advocates, we as research advocates, we need to conduct research to understand the complexity of this journey and how we as advocates, we can use that information to better serve our community. Which brings us to the discussion of today's topic in the next slide, please. So today I'm going to be talking about a project that Longevity Foundation has been conducting, and it's called Project PEER. And it's an international, so patients from anywhere in the world can participate, observational patient and caregiver experience study. And what do I mean by observational? I mean a study where there is no treatment given. So it's a survey-based study. And this particular study asks some of those fundamental questions. How does patient experience change when a patient moves from first line of therapy, which is the first treatment that a patient receives, to the next line of therapy? Now, this is a very important question that came to us from the lung cancer community, and I'll tell you why it's an important question. 10 years ago, the average patient diagnosed with lung cancer probably went through 2 lines of therapy, and that's because we didn't have a lot of treatment options. But fast forward to 2021, 2022, now most people diagnosed with lung cancer will have access to at least 3 to 4 lines of therapy. Now, as people are moving from one line of therapy to another, are they experiencing the disease differently, and are their needs different? So that is the fundamental question we are trying to unpack in this study. And what you see on the right side are all the different questionnaires that we used, and I have boxed 2 questionnaires that I'll be talking about, the EORTC QLQ C30 and the EORTC Financial Toxicity Survey. Now, these 2 surveys are validated, regularly used patient-reported outcomes, or PRO instruments, that are used routinely in clinical trials. And here we took those same instruments and we used them for our study. So what that does is it not only helps us understand the patient experience, but we can actually compare this data eventually with data from patients who are on clinical trials to see. But that's sort of the long-term goal of the study. But I hope I've explained to you why this study is important to really understand how patient experience changes. So next slide, please. So let me tell you a little bit about first how the survey was developed. The survey was developed in partnership with patients from both the United States and patients who are located outside the United States, and in collaboration with other stakeholders, clinicians, pharma sponsors, drug makers. And this survey actually came from some of the seminal work that we as in Longevity did with the EGFR resistors, where we did a similar international survey very focused on the EGFR population. So again, this was a study that really originated in the lung cancer community. And a patient or a caregiver, they complete one baseline survey. So at the time they start the study, and then they complete 11 monthly surveys. Now, today I'm going to be talking very specifically about those patients who are diagnosed with stage 4 disease and how their experience changes when they move from first-line treatment to subsequent line treatments. So the total population that I'm talking about is 174 patients, and about half of those patients are on their first-line treatment. So that's the treatment that they started when they were first diagnosed. And about half of the patients are on their second and subsequent line treatment. So next slide, please. So this gives you a snapshot of the patient participant demographics. As I mentioned, a total of 174 participants were included at the time of analysis, and the study is still ongoing. About 10% of the entire sample, so about 18 patients, are international patients. 86% of this population are women, or they identify as women, I apologize. And the age range is between 29 and 76, with the average age being 55. And that age range that you see, 29 to 76, is a good reminder of really the big demographic shift that we've seen in the diagnosis of lung cancer. We have really young patients right now navigating the disease. And on the right side in the table, you see the education level of the participants. And these types of demographics are very, very common when we are sharing data from these types of studies. So now let's move to the next slide and get into the data. So this is really looking at the quality of life based on whether someone is on first-line treatment and someone is on second-line treatment. And you see different domains here. Physical functioning, can I climb stairs? Emotional functioning, do I feel happy? Do I feel good? Social functioning, am I able to do things socially, go out with friends? Role functioning, am I able to do things that I'm supposed to be doing as the role that I play in my household, the role that I play in my workplace? Cognitive functioning, do I feel mentally capable and well? Global health status, this is the overall health status of me as a patient. And again, these questions are standardized. And what you see on the two sides, so let's start with the maroon table on the top. And what I have there are mean scores. And so those are the mean scores. So that's on an average how patients on first-line treatment feel. So you see that physical functioning, the mean score of patients are 82. But let's look at the blue numbers now. So the blue numbers are patients who have moved from their first line. So either they're on their second or subsequent line treatment. And as you can see in each of those domains, the scores, the average scores, the mean scores are much less than patients on their first line treatment. So you see a clear decrease in the quality of life. So this slide, using these validated questions, very clearly shows that patients on second and subsequent lines of treatment, they experience a decrease in quality of life as measured by these PRO instruments. Now, let's go to this next slide. Next slide, please. I apologize for the fonts. They're a little light. I hope you can read. So this one looks at a question that's of fundamental importance to all of us as advocates, as research advocates. Financial toxicity associated with lung cancer. Now, the first column you see is patients on their first line, and the second column, you see patients on their second or subsequent lines of treatment. Now, that very fundamental question, has your physical condition or medical treatment, has your lung cancer caused you financial difficulties? Now, 27% of patients on their first line treatment report having some financial difficulty, but when you look at the parallel column, 56, double. The number doubles essentially when you look at patients on their subsequent and second and subsequent lines of therapy. So just that very simple question tells us that financial toxicity is increasing as patients move from first to second and subsequent lines of therapy. Now let's look at some of those granular questions. And I'm not going to go through each of them. I'm going to just pull out a few. As a result of your physical condition, as a result of your medical treatment, as a result of your lung cancer, have you lacked money to buy basic things like food or clothes? Again, 11% patients on their first line, more than double. A quarter of patients on the second and subsequent line therapy, they report saying that they've had some difficulty. They've lacked money to buy basic things like food or clothes. Now let's look at the last item there. Have you had to borrow money or sell personal belongings? Again, drastically increased in patients who move from first to second line therapy. And this is all advanced stage patients. Let's keep that in mind. So then moving on to the last slide. Next slide, please. Hopefully I've convinced you that the impact of lung cancer treatment is cumulative. So as someone is going from the first line to the second and third line, fourth line treatment, the impact is cumulative. There is a decrease in quality of life, and there's an increase in financial toxicity. And I hope you've seen both sides, decrease in quality of life, increase in financial toxicity. And this is something we as advocates, we as researchers, we as members of the healthcare ecosystem, we need to keep this in mind, because this kind of data needs to be incorporated in policy decisions, in education, in treatment decision-making, because we don't do enough of this. Doctors should be having candid discussions with their patients. Okay, you know what? There's going to be a treatment switch. You might have to move from first to second line therapy. So let's talk about your financial situation. Let's talk about how you're feeling. So hopefully I've convinced you using this data that impact of lung cancer treatment is cumulative. And we need to be using this information to better serve our community. So again, thank you for letting me present this work. And most importantly, it's a privilege to be able to be the voice for our community in such an important forum.
Hi, thank you, everyone. And I want to say thank you to ISLC and for allowing me the ability to present some of the work that I and GoTo presented at the World Conference of Lung Cancer this year. So increasing targeted therapy options have made comprehensive biomarker testing an essential part of lung cancer treatment selection, although as we know, right now, the standard practice for biomarker testing is to send out to a third company for testing and have the results reported back to the doctor who orders it. However, standard practice not to return the results directly to the people with lung cancer, but rather the doctor. So it's been suggested in other places that if you provide people with lung cancer testing, patient-friendly testing summaries, it could potentially increase the amount of involvement in the discussions around targeted therapy and picking appropriate therapy, and actually lead to a greater chance of having the right kind of therapy started. So we just thought to determine the one patient desire for a patient-friendly summary report that could be included with standard biomarker results and the preferences that people might have for what should be included in a patient-friendly biomarker testing summary. So the way we approached this is we conducted focus groups and interviews directly with people with lung cancer and or associated caregivers. And our interviews kind of focused on four main areas. First, we asked about the reports people are already receiving from biomarker testing companies and how well they understand them and are satisfied with them. We then asked about educational needs around both lung cancer mutations themselves and associated targeted therapy treatment options. And lastly, we asked people in our focus groups about their preferences for what should be in a patient-friendly biomarker testing summary report, what kind of information they'd like to see, and what parts of the report are important. Using that data that we gathered from those interviews, we identified and came up with elements and a format of a potential summary report and generated drafts of it. We then worked with a multi-stakeholder advisory board, so basically different kinds of people that are involved in the biomarker testing process, from providers to biomarker testing companies to people with lung cancer themselves, to finalize the report and what it should be. So I'll talk first about the focus groups we conducted and the information that we found. We really want to recognize that lung cancer communities, there are many people in it, and there's not just one type of person with lung cancer. So in order to capture kind of the broad patient experience, we focused on interviewing three main groups. The first were people with lung cancer that had received testing before but didn't have an actionable mutation found in the original biomarker testing results. The next two groups, we previously received testing, did have an actual mutation found in their biomarker testing, but differed in whether or not they were involved with one of the patient-led mutation-specific groups that are available in the lung cancer community. Group 2 had not been previously involved in a group like this, and Group 3 were either leaders or active members in such a group. And to get to some of the feedback we got from our focus groups, first we asked about the currently available biomarker testing reports that come back from testing companies to patients. Generally, what we heard from every group is that the reports were a little bit confusing or had qualities they didn't like across the board. Specifically, Group 1, who is that group who did not have actionable mutations, found reports confusing and said that they included a lot of information they did not understand. Specifically, they said it was unclear to them if non-actionable mutations that were listed were relevant to their situation. Group 2, who was not involved with patient mutation groups, said that the reports adequately conveyed treatment options for actionable mutations, however, were a bit confusing on the importance of non-actionable mutations, especially at the time of progression. Group 3 felt that through their experience working with these patient-led mutation groups, they were familiar with and understood the reports, but many of the people they interacted with did not feel the same. So we're generally seeing a desire for some kind of patient-friendly, framing of these results and for a patient-friendly summary report. So with that in mind, we moved on to asking the groups what they would have as different elements in a hypothetical patient-friendly summary report. What you're seeing here are the rows in the table represent different elements of a potential report we asked about, and columns represent the responses we got from each one of our groups that we interviewed. First, focusing on the level of information the report could have, Groups 1 and 2 both said that there should be a high level of information, even if it involved linking out from the report. Group 3 said that the reports could contain too much information, however, at times, and could cause hyperfocus on inappropriate information. We next asked about clinical trial information, since a lot of biomarker reports currently include a list of all potential clinical trials. Group 1 uniquely felt that clinical trial information should be included, although they did admit that it would be better if it was recent clinical trials and were relevant to their particular situation. Groups 2 and 3 felt that clinical trial information should not be included because there were too many, especially at the time of later lines of treatment. And Group 3 said information can become outdated very quickly and cause hyper-focus on inappropriate trials. We asked then whether the report should include information linking people to the patient-led mutation groups. Perhaps not surprisingly, Group 1, who did not have actual mutations, said they wouldn't find that information helpful, but the other groups did. And lastly, we asked about how actionable mutations should be presented when they were found on a report. Both Groups 2 and 3 said that they would include information on related treatment options as well as background on the mutated gene itself. So taking that in mind, we designed a patient-friendly summary report. working with our stakeholder advisory group. We decided in the end to make this one page front and back in length to increase brevity and understanding and to focus on minimizing health literacy requirements. Based on the feedback from the group we said that actionable mutation results should be call out approved treatment options and provide background on the gene itself. Specific clinical trials should not be listed based on the majority feedback we got. And we recognized that there was diversity and preference in some areas among our focus groups. So we favored making a template report that would allow individual providers to tailor this to their individual situations when they were working with patients. So in conclusion, we really found that there is a desire for a patient-friendly summary report among lung cancer patients, and we really feel that the biomarker testing stakeholders in the lung cancer community should work together with advocacy and patients to develop this. The report preferences do differ among patients, but there are a lot of common elements that can be identified as we outlined here. And we do acknowledge that there's some future work. Future studies will be needed to make sure that when we hand reports back, they actually improve the patient experience and lead to good outcomes. And that there are going to be some implementation barriers, and further work is probably needed to make sure that we're getting the reports to patients in the most practical and best way. So I just want to say thank you for your time, acknowledge my collaborators, and really importantly, each of the people with lung cancer and the caregivers who shared their experience and perspectives and the time that they took to help this out. So thank you for your time today, and I'm going to introduce the next speaker, Jill Feldman.
Hi, everybody. First, I just want to thank IASLC for the opportunity to present this work and all of you. So our study was on early adopters of the IASLC language guide. And while there have been incredible advancements in research and treatment for people with lung cancer, as many of us know, the stigma remains a deadly problem. And there's an undeniable blame culture in lung cancer that you don't see with other diseases. Every other cancer elicits empathy with responses such as, "I am so sorry," or "What can I do to help?" Pure sympathy, no blame attached. But for most of us living with lung cancer and our loved ones, the very first question we are asked is, "Did you smoke?" And those three words, this seemingly innocent question, may appear harmless to many on the surface, but it carries significant consequences and implication. And research shows that lung cancer stigma negatively affects every facet of a patient and their family's experience, including barriers, diagnosis, quality care, and support. Just like lung cancer, it poses grave consequences. And therefore, like research and treatment, the language that we use needs to promote empathy and oppose judgment. So, words matter is not just a catchphrase. It's a simple yet profound truth when talking about lung cancer. So recognizing the urgency to combat stigma and to actually promote patient respect and dignity, the IASLC language guide was created. It was a collaborative effort between IASLC patient advocates and the National Lung Cancer Roundtable Stigma Task Group and other, people from various disciplines and different organizations as well. The guide is not an exhaustive list of do's and don'ts or rules, and it's not meant to call anyone out. In fact, it's meant to call people in. The purpose is to raise awareness and promote inclusion. And so the guide was approved in 2021 by the IASLC board, unanimously approved. And our study analyzed, while it was created for abstracts and presentations, really, truly, our goal is for the entire community to start using this kind of language. And so our study looked at presentations from World Conference 2022, just 1 year after the language guide was approved, to assess the adoption of non-stigmatizing language within that first year. And we wanted to see if there were correlations with that and with presenter characteristics. So we focused on the term smoker because it is the first word in the list of stigmatizing language in the guide. Notice smoker, it is labeling patients by a behavior. We're not even, it dehumanizes us completely. And so we did a search of its usage in the presentations, and then we explored also presenter backgrounds. 177 of 519 slides did discuss smoking status, and 43% used non-stigmatizing language. As you can see, we found that non-stigmatizing language was embraced more by PhDs and other categories, including RNs, MS, and patient advocates. But the key takeaway from this is that all groups exhibited positive change. If you look also at that, there wasn't necessarily a statistical significance in the other categories, but again, the diversity in continents and specialties shows promise, as does seeing a change in the way people are talking about lung cancer. So the ISLC language guide has already made significant inroads within our community, as seen, as I just showed you, but it's also gaining traction beyond our community. I think one of the greatest impact lies in the influence outside of the lung cancer community, actually. The National Comprehensive Cancer Center or Cancer Network, they recently put out a guidance on language that actually cites the language guide. And NCCN serves as the primary go-to resource for clinicians and insurance companies in determining care pathways. So this is huge. It's a significant and pivotal endorsement. In essence, it should be a game changer. But of course, change comes with challenges, and we recognize that. And old habits die hard. We know that language isn't static, and neither is the language guide. We're actively working on a second iteration to address some of these known challenges. And such as, research with regards to tobacco, presenting data in tables and figures, word limit concerns. And we've started initiating discussions about a dissemination plan and developing like metrics to measure its success on a larger scale. And we also recognize that while this is a crucial step, it's not the only step that needs to be taken. We're also really trying to work on the way that research is reported top down. So it's consistent, it's not subjective, and it's reported in a way that patients and caregivers can understand. As it is now, those of us that don't have a PhD or MD still labor through the science quite a lot. There were a lot of people that were involved in this that, we're grateful for, but really, truly, I think, the fact that IASLC took the lead in changing the way we talk about lung cancer to help shift that focus from shame and blame to compassion and non-judgmental language is huge. Medical language is rooted into tradition and historically used to describe cancer. But over time, we've learned that some of the words and phrases are harmful. And, patients also used to not go to conferences or necessarily read journal articles, but now we do, and we hang on to every word, and ISLC recognizes that. You know, it really, when we talk about lung cancer, you know, we really need within the community as well to promote dignity, respect, and person first language. And so I am, you know, again, really grateful for everybody that was involved in this, and we'll be doing more work in this area. And our goal was to document how people are looking at it. And we were really pleased with what we found so far. So thank you. And last but not least, is Anne Marie.
Thanks, Jill. So it's really nice to be here with all of you, and hopefully that's worked okay. So I'm going to talk a little bit about the presentation we had as part of Lung Cancer Europe at the World Conference on Lung Cancer. So thanks for having me here tonight as well to talk a little bit about it. And I'd just like to say before I start that unfortunately Mario Forsblom, who's here on our slide and was part of our Lung Cancer Europe board, passed away last week. So a very difficult week for all of us in Lung Cancer Europe. So with that, the project that we undertook was really to try and look at the lung cancer care pathway. And as Upal has already said himself with that slide that he had shown, it is becoming more and more complex. There's so many different treatment options, so many different things that can go on along the care pathway, and it really is becoming quite difficult to navigate. And there really is, particularly from a European perspective, very limited understanding of the suitability of the delivery. So how this pathway is delivered, and is it being delivered in a person-centered approach? So the aims for our study was really to try and explore the experiences and preferences of people impacted by lung cancer across the care pathway. And we also did a deep dive into European countries as well, but I'm not going to share that data here this evening. So in terms of our methods, really this was an extensive literature review. And from that, we developed an online survey using SurveyMonkey. So Lung Cancer Europe is a members-based driven organization. So the topic for this report came from our members. And then as part of that, we developed working groups. So there's a number of people that come onto these working groups to help develop the different projects. And in this case, it was no different. People inputted into the survey, whether it was prioritization of questions or the language that was used to frame the questions in the survey as well. And of course, being Europe, we have to try and work in as many languages as we can. And in this instance, we were able to have the survey active in 17 languages. So just a brief overview of some of the main characteristics from our participants. So the majority were female and 55 to 64 age bracket. And this is really in keeping with what we've seen in previous surveys that we've had. Although our age range did vary from about 25 to 75 plus. The majority of our participants were also living with stage 4 disease, primarily adenocarcinoma. And of those, nearly 60% had said that their tumor was positive for some type of molecular marker. It should be said, however, from the data that there was about 26% of those that participated actually didn't know if their tumor had been biomarker tested or if their tumor was positive for any biomarker test. So this links back into what Andrew was talking about as well in terms of biomarker testing. And the majority of our respondents were also from urban areas and had tertiary education as well. And I should also say that about 50% of our respondents came from France, Germany, the UK, Poland, and Greece. So if we initially look just at some of the data from the diagnostic part of the pathway, because we divided it up into a couple of different portions, really there was a lot of issues here around issues in terms of earlier diagnosis. And throughout Europe, lung cancer screening is not something that's implemented in very many countries. So you can see that lung cancer screening programs really is the key thing that was identified among our participants. There's also a lot of data out there showing that people have to go to their primary health care doctors a number of different times before they get referred on. So education for primary health care doctors was something else that was identified amongst our participants, as well as things like shortening waiting times and educating the general public about lung cancer itself. In terms of looking to at priorities to improve the diagnostic pathway, again tying into those wait times was about fast-tracking services that reduce those wait times. Sometimes within the pathway you might be dealing with a number of different people, so it was felt that it was really important to have one primary contact that people could get in touch with if there was an issue or a problem. And also, given that the pathway itself is so complex, to make sure that there really is a clear roadmap and clear information about what is happening and what might be happening next. So that all led into then about how to improve communication and the priorities around that as well. And really this centered on better communication skills, whether it was empathy and clarity of the message, to also education about side effects and how to reduce the risk of complications as well. Looking at the treatment pathway, there was a number of different spheres that they felt were not addressed adequately enough by their healthcare teams. And again, I don't think this will come as any surprise to anyone, but really these centered around the emotional, physical, and social needs that people were experiencing. What they found most difficult to manage in the treatment part of the pathway was really the anxiety. There was a lot of anxiety around the treatment, which is to be expected. But when we look at surgery in particular, there was a lot of difficulties around managing the pain associated with the surgery. And then if we look at pharmacotherapy and radiotherapy, it was really difficulties around weakness, fatigue, and how to manage that, as well again as that stress and anxiety that people felt. And there was other issues identified, but these were really the key issues that stood out. In terms of priorities for during and after treatment, it was all really about guidance, help, and support as to what people could do to reduce the risk of complications. People really want support to manage side effects, particularly when it came to pain management. But of course, this meant that you need to ensure that allied healthcare professionals were there and part of the pathway, and there was an easy referral to them, as well as by education around self-managing the disease. And that, as I mentioned before, that primary point of contact and that improved accessibility to the medical and nursing team themselves. So when we look at information and communication needs, this was across the entirety of the pathway, but I've grouped it here in its own sort of section. And really it was making sure when you particularly come to the treatment decision, if you want to have true shared decision making, is about understanding what treatment options are available, advantages and disadvantages of those options, and what the associated potential side effects and risks may be of those different treatment options that are available. There was some information and support needs as well that were missed during the follow-up phase in care, and that was around looking at what the symptoms of recurrence might be, managing maybe the long-term consequences of the disease itself and treatment. And again, that access is really, really key, ensuring rapid access to health services when you need them, irrespective of where you are in the pathway. There was also information needs in terms of the treatment pathway, and a lot of this was to do around clinical trials. A lot of people felt there was just not enough information on this, and those emotional and social issues that people face, again, they did not feel that they were getting a lot of information around that. And a number of survey participants also selected the need for having information around advanced care planning, as this seems to be something that's often forgotten about within the care pathway itself. One thing that I haven't shown here, but it was something that came out from this data as well, was around informed consent. And in our study, we found about 47% of our participants felt that they had not received all of the information that they needed before they actually went on to sign informed consent forms. So really, it's very much broader information and communication needs that have to be addressed. In terms of the take-home messages from this study, well, again, this is from a European perspective. So it was all about making sure there's that implementation of lung cancer screening within European countries, the need for rapid referral pathways, because there can be a number of barriers and blocks in timing going from one to the other. And really key throughout any of the aspects that we looked at was the need for improved information and communication, as this really impacted so many different things in terms of the pathway itself and in terms of the outcomes people were experiencing. So with that, I will hand over to Janet Freeman Daly, who will moderate the Q&A.
Thank you, Anne-Marie, and I invite all of our speakers to come back on. Thank you. Thank you all for sharing some of the important work that research advocates do to improve outcomes for patients who have lung cancer. I have a few questions that are going to focus on how people get involved with these projects and how they get started. So how did you get involved with your individual projects and what was your role? Anne-Marie, I'm going to have you go first.
So how this project started with Lung Cancer Europe is that all of our members come together at different times throughout the year, and there's different priorities and needs that they bring. And then what we try and do then is rank them and see how best we can do a project around that. So in this instance, we had done some other work around the psychosocial impact of lung cancer, and our members felt then that it was important then to follow up that on with experiences within the care pathway. And really my role was just helping in terms of the working group, getting people together. But of course, with any of these things, you also need experts. So we're very lucky to have a group that works with us as well in terms of doing the literature review and putting everything together and helping with all of the different translations that had to be done, because 17 languages is quite a lot to go in at any one time.
It is a lot.
Yeah. You need someone who's got the time, who's going to be able to manage all of that.
Thank you. Andrew?
Yeah, and so I think the reason that my organization started focusing on this question is that just two things. One, the data that we were kind of seeing from a lot of healthcare systems, including some big ones like US Oncology Network and other things, that not everyone was getting biomarker testing, and also that many people that were getting biomarker testing were not actually being started on an appropriate targeted therapy. And so that became a really important issue to us. And we were hearing anecdotal feedback from some of the people that called our patient support services and other things about the kind of inaccessibility of some of the current biomarker testing reports that come from companies. So we really decided to focus on this, and we asked around, and we kind of asked the question, why is nobody trying to make a patient-friendly kind of biomarker testing report? And we found that it really wasn't going to come from some of the industry partners just because of the way it works. So we decided to take it on ourselves and start forming the kind of basis that could kind of spur on the community. So specifically in the project, I worked for someone really closely at the organization. I focused more on kind of the designing the questions we were going to ask and how we'd kind of approach getting the information, making sure that the suggestions we gave for a report were reflective of the patient experience, and then someone else dealt with actually connecting with the patients. But it's like partnership, like a lot of things.
Takes a team.
Absolutely.
Jill, how about you?
So this really started from personal experience, obviously, with my family history. So starting when I was 13, and it was probably about 10 years ago, I started to see some divisiveness within the lung cancer community as well. And words matter, and I really tried, 10 years ago, I had one person say to me, one professional, sticks and stones. Or in another one, or many say, you're being too sensitive. And so when in the fall, I think it was the fall of 2019, when IASLC broke out into patient advocate committees, I proposed doing the language guide as one of them, and really knowing it would be a work in progress, but really starting with language used in research, abstracts, and presentations. And I was also working with the National Lung Cancer Roundtable Stigma Task Group. So to me, the synergy was there, and just kind of brought everyone together, and other disciplines and people and organizations as well. And I guess people were ready to listen at this point. And so it was really, it was a labor of love, and many, as Kristen Ito would say, many hands and hearts really put into it. So it was, yeah.
Thank you. Upal, how about your project?
So our project really started in 2019 with a partnership with the EGFR resistors with Jill, Ivy, Anita, and Terry. And that particular project was looking at patient experience in the EGFR community. And that particular project was the foundation for Project Peer, the data that I presented today. And it is really sort of entrenched in the needs of the patient community. And I would say questions that are pertinent to the patient community, right? Because no researcher, no pharma company is going to really spend time and effort trying to understand how patient experience changes as they move from classes of therapy. So it really is on us, research advocates, to first come up with these questions and drive this research forward. The other piece on Project Peer, which was equally critical, is as patient research advocates, we were very attuned to the fact that we also need to get other stakeholders bought into this project, because we can do a project by ourselves, but if the data is not utilizable to other stakeholders, if other stakeholders don't buy into this project, then it's a futile experiment. So therefore, we concertedly worked with the FDA as well. And as I mentioned, one of the pieces of this project is to be able to compare patient experience in a clinical trial setting, because people are already collecting that data, with this sort of real world experience. So that's how this project started, and that's how we sort of brought the value proposition to the broader community.
I'm hearing a common theme here, that there was a kernel of an idea, but in order to get the project done, it required coordinating a lot of people and bringing the community together to get it done. So with that in mind, how long did it take from the time the initial project was conceived to be able to get this data that you could present? I realize you don't have exact count of months, but a ballpark. I'm going in reverse order this time. Upal.
I actually do have exact number.
Of course you do.
So Project Priority was started in 2019, and Ivy and Jill, they presented different parts of Project Priority research and different word lungs in 2020, actually 2019, 2020, 2021. And Project Priority was wrapped up, which is the EGFR project, and we're actually writing up the manuscripts. So that's 2019 and 2023 where we are at the manuscript phase. So that should give you some idea. And Project Peer started in 2021. And last year we presented initial findings in 2023. This year we presented a little bit more detailed findings of the study. So I think patience and persistence is key, because really doing a rigorous study which has stakeholder buy-in takes time.
Andrew?
Yeah, so, there are countless conversations kind of, forming the idea for a while, but I think getting the project off the ground, we started about 6 months before we actually started the project. We needed to get people in place to help us, do the analysis and help us plan the project, and also to get kind of the funding resources we need to carry it out. But from the time we started the project to the end, it took about a year to actually gather the people, conduct interviews with patients and caregivers, and then analyze the results and generate template reports.
Thanks. Jill, if you don't count all the years you were thinking about it
Oh,
before it
yeah,
actually
no.
happened.
For this particular one, for this particular project, it really was a few months. Because it was there, we just had to go through all of the presentations from 2022. So it took probably, I don't know, maybe 3 or 4 months to really go through it all, with the purpose, we were happy with what we found. We were hoping that would be the case. It could have gone the other way, but we're starting now to do a more in-depth one.
Okay. Anne Marie?
So for us, it was probably about 12 months, but that's because, it's about bringing people together and having people who are going to help and assist. It really is that team, as you mentioned, Janet. And what we're trying to work on now is getting peer-reviewed publication from the data. So that's going to take a little bit longer.
Well, we have a couple of minutes, so I'd like to get feedback from each of you. What do you think a person who is involved in the lung cancer community as an advocate, what can they do to start getting involved in projects like this? What would be some first steps? And Jill, I'm going to grab you first.
I think there's different things you can do. One of the things is talk to other people. I like to ask a lot of questions, and I will reach out to random researchers or advocates or people, because if I'm really interested in something. And so just a quick example, I did it recently with something else that I'm really interested in, which is dosing. And so I reached out to a researcher who I started talking about something, and we started brainstorming. So Janet, that I reached out to that person in Oregon about PROs. And so I just tend to be persistent like that. But I have to tell you, they are very willing to talk and work with you.
Andrew, I'm going to grab you next.
Yeah, I would just add on the importance of partnership. For I think when we have an idea as advocates, I think one of the first things is to not be afraid to share it with others. I think that can be the hardest first step, but none of this we can do alone. I often find that a lot of the projects that I start I have an idea or a couple ideas, and I don't directly go out pursuing them, but I try to involve myself in places where I'll network with other members of the community or other places and just share my ideas. And a lot like Jill said, sometimes you'll meet someone who says, that's a really great idea. What have you thought about it this way? And then you'll eventually start to, make the connections that you need to make. And so I tell people, getting out and getting to meet members of the community can be really important.
I would love to continue asking this, but we're at the top of the hour. So thank you to our speakers for presenting today, and thank you to everyone in the audience for joining us. And we'll see you next time.
Thank you. Bye, everyone.
Thank you. Bye-bye.
Thank you. Bye.